Good day, everyone. Welcome to our webinar. My name is Chip Burgett, and I'm going to help in leading our discussion today. The subject for our discussion is bundled rates for surgical procedures and the positive impact bundles can have for plan sponsors. We're going to provide overview today, and hopefully in future webinars, provide more details on the bundled programs. We've got a great panel for this discussion, and we're thinking we're going to have a fairly lively discussion. Before we start, just a couple of business issues. As participants, your audio is turned off. We invite questions. There is a Q&A tab in the lower right portion of your screen. Click on that, type your question in. We've allowed plenty of time at the end of our session to address questions. So let me start by introducing our panel. First, Ken Stuart. Ken is the chairman for the California Healthcare Coalition. Ken has deep experience in the operation and administration of benefit plans. In addition to his work at the coalition, Ken has served in an administrative capacity for the San Diego Electric Health and Welfare Trust, the San Diego Electric Pension Trust, and served on the NECA IBEW Drug-Free Workforce Program. Ken, welcome. Give us a wave.
Thank you.
Next, Mike Larsen. Mike is Executive Director for Municipalities, Colleges, Schools Insurance Group, otherwise known as MCSIG. MCSIG is a joint power authority program based in Monterey County in the Central Coast. For those of you who might not know what a JPA is, basically it was enabling legislation in the state of California, allowing public entities to combine for the purchase of insurance programs. Mike also serves as chair for the California Purchasers Healthcare Coalition, is a former member of the California JPA Legislative Oversight Committee. And before joining MCSIG, Mike was in the hospital business as a chief financial officer. Mike, give us a smile.
Morning, Chip. Happy to be here.
Last but not least, Scott Leggett. Scott is co-principal of Global One Ventures. Scott is one of the earlier developers of bundled rates for surgery centers beginning back in 2009 and uniquely high acuity procedures for surgery centers. Scott's got a long history in the healthcare market, starting out in the clinical side in physical therapy, later as an operator of multiple surgery centers in the San Diego market. Scott, say hi to everybody.
Morning.
So with that, we're going to begin, jump right into it. Ken, maybe just background on your coalition activities and challenges your members see and face right now in terms of delivering healthcare benefits for employees.
Sure. The California Healthcare Coalition is a 501c3 organization whose members all have a labor management background and foundation. We have approximately 1 million lives, and we represent public pooled school districts, Taft-Hartley plans, construction trades, and various labor and management organizations. Basically, what we do is we get together and we aggregate and disseminate information to our purchaser members to make them more effective, better purchasers. Obviously, the focus is on cost containment and controlling our costs. The CHCC board members all hold seats or have held seats with some very reputable organizations throughout the state, many as chairman. And I know many of us share the same philosophy I do, which is plan sponsors need to do anything and everything possible to control their costs, reduce their costs before they pass more through to their participants and members. The chart before you basically shows how effective cost containment can be. This is a listing of all of the IBEW local unions in the state of California and the employer's hourly contribution rate. I'm pleased to say that San Diego, being on the top, is the lowest, and you'll see in many cases by far. And this is just reflective of what we've been able to accomplish with programs such as bundled surgical pricing through Global One. Can I get the next screen, please? This shows you from 2004 through the present how much the hourly contribution rates for all of the IBW locals have increased. And I think you'll see that there's been an appreciably lower increase in San Diego, again, reflecting the proactive cost containment that we've taken. Thanks, Chip.
So Mike, maybe to you, certainly MCSIG faces unique challenges in terms of providing benefits for your members. You want to just address some of those issues and maybe talk about what led you to consider bundle payments as an option?
Happy to, Chip. Before I answer the question about why we sought that, just a little bit about MCSIG. We're a joint power authority, like Chip said, and were formed back in 1982. I love this slide because we're in education and they tell you always put something that's a little off on your slides. So I can do math. I know 1982 to present is not 35 years, but it's a fun one to see if you're paying attention. So we've got 6,200 PPO members, mostly in education in Monterey County, but do have groups throughout the state. And you know, we love to get our members healthy, keep them healthy, and go to really great providers when they need it. So that's kind of our strategy. Could I get the next slide? So this is a picture, some of you may have seen this on national television, the Pro-Am that happens here in Monterey County, out at Pebble Beach. Beautiful area, but very, very expensive here. Monterey County boasts 2 of the most expensive 5 hospitals in the state of California. And it's just really expensive here. Next slide. So the big challenge we face, and before I share this next slide, I just want to make a fun comment. So when we go out and talk to different groups about benefits, one of the benefits they never believe is that we pay people to go get surgery. And I'll just repeat that. We pay people to go get surgery. And a lot of people look at me like, you're crazy, nobody does that. And let me explain why we do. So costs in Monterey County, you know, are 50 to 160% higher than usual and customary. And we run 20 to 30% more expensive than Los Angeles or California. So it's a really expensive place. The solution we identified was working with the local ambulatory surgery centers with Global One, to pull them into a network. And we had been traveling members out of the state. So we were sending people to Phoenix and down to San Diego and to Montana and other places. But, you know, that was a big challenge. And so we had a program in place. We were incentivizing members, but we were hearing back from members that it was a struggle to go different places. So this program, we waive all of their costs. Even if they want to travel, they can, you know, still go down to San Diego or other service places. But in 2014, we got the 5 local surgery centers through Global One engaged in this network, and it really took off. So the prior 3 years, we'd seen a few surgeries every year, but it just really was a big challenge. So we were super excited that we got these in place, and our members wouldn't have to travel anymore. Obviously, quality is really important for us, so we didn't want to just send people anywhere. And so we worked with Global One and Bridge Health to make sure the bottom 3 quartiles of providers were excluded. And that had a huge impact too on quality that I'll talk a little bit about later.
Great, thanks, Mike. Ken, just quickly, thoughts on bundles. You've had some experience in that. Was your experience similar to Mike's?
Yeah, it was. We realized that by bringing in the surgery and anesthesia to a much lower facility and in a joint replacement instance, putting that all together was extremely advantageous.
Excellent. So Scott, shifting to you, maybe explain the kind of unique provider structure that Global One uses and why that's effective in delivering bundles.
Great. Yeah. So first of all, just appreciate the partnership we've had with Ken and Michael, and I've learned a lot from these guys over the years. And so what we've done, and what I like to refer to as our network, we're basically a very focused network. I like to refer to it as a marketplace that we've created of surgeons, assistant surgeons, ASCs, and anesthesiologists, and have connected them together in a we're concentrated in markets, as was talked about earlier. Traveling patients, the engagement has not been as good. That's been our experience of what we learned through this process. So concentrating our providers in markets gives us better access for the members. We provide quality reportings around that network. Essentially, we're a direct access point to the marketplace of high quality providers, for the payers and the plans. And we have preset bundled pricing. So we have, we started in California, so where our roots are at. Right now we have over 150 surgery centers in our network statewide. We're over 1,000 surgeons now. In 2019, we did a little over 4,500 bundles in 2019. So, as Chip mentioned earlier, we've been at this for over a decade, growing each year, and we've learned, continue to learn year to year, and very sophisticated network at this point. Next slide, please.
Hey, Scott, can I just jump in with a question?
Of course.
You mentioned preset bundles. A lot of carrier programs offer retrospective bundles. So maybe just talk about the difference quickly.
Sure. Yeah. So a retrospective bundle is basically providers, or it's a look back approach where the providers is basically the BPCI, the Medicare bundles, are retrospective bundles. So their providers are basically providing care as they normally would, and then it's a look back and see how well you've managed the pricing and utilization in those bundles. The prospective bundles is the commercial bundles that we've employed, is basically a preset pricing. So we go at risk for the price. We guarantee a price to the plan, to the patient, probably most important to the patients, all transparent. And there's a defined amount of services in that bundle. The bundle can range depending on the member or the plan. Some are basically an episode around the day of service, and some of the bundles are 30 days, 90 days, and that's really a personal decision. Kind of goes under what I call a bundle is really not a bundle. It really is what the plan wants and how they want to execute on what they want in the bundle.
Great, thanks.
So the procedures, we have over 70 bundles that we're offering now. We continue to add. We have about 60% of those are in orthopedic and spine. We have general surgery, cardiology, ENT, women's health. And we are in the process, thanks to Mike, been kind of looking at obstetrics and cancer bundles as well.
Great. Mike, you addressed some of the issues relative to engagement, but in programs like this, really across the country, getting plan members engaged, that is, getting them to identify the program, to utilize the program, is a huge challenge. Can you talk more about that? Because I think it's a key issue.
It really is, Chip, and thank you for the question. So we kind of did a triumvirate of different things to educate our members, and so we have a huge wellness program, and we've paid out $500 a year for a long time. This last year we pared it back a little bit, but whenever we go out and talk about our wellness program, we also talk about surgical bundles, and we also talk about free mail order generic drugs, and we talk about telehealth services that our members have access to. So our utilization's been about double what other pools have experienced, just because we get people really engaged and educate them on these issues. The other thing that we've done, and collaborating with Global One and the local surgery centers, if you go one slide forward, there's a really neat poster that we got up in all of the offices of the local ENTs, orthopedists, others, so that when people were visiting with their doctor, there's this poster hanging on the wall with information down below about how to engage in this program. And so one of the unique things we were able to do in Monterey that has been really a tough struggle other places is providers were our best referral source. So every year for the past 6 years, five and a half years, 50 to 60% of our bundles actually were doctor referrals where somebody's sitting in their office. And, as I've talked to dozens and dozens of doctors over the years, they said, you make us a hero for this member who needs something, and we can get it to them for no cost out of their own pocket. And we do give back money to the members. We have a shared savings rebate back to them as well. So, this was really engaging for our members, and thankfully to the local providers, they were on board. And so it made a huge, huge impact for MCSIG.
Great. Ken, I know you've worked hard in the past in terms of trying to get busy electric workers to, be cognizant of benefit plans. Talk a little bit about that for us.
Sure. I'm sure everybody on this call, if you've been involved in trying to engage your participants with anything pertaining to your plans, you probably share the same frustration I've had over many decades of the fact that people don't read the notices, they don't read their plan booklets, they don't really understand what their plan is or how to make the best use of it. To me, it comes down to a simple universal language of how much is it going to cost the person, and dealing in that paradigm is what will get their attention. But what we're dealing with is in San Diego, we were getting hospital bills just for the facility and the replacement joint for a knee and a hip of over $100,000. You then have to add in the surgical charge, the anesthesia charge. So the concept of trying to get our participants to think in terms of stepping out of the box and using Global One and on a bundled approach made the most sense. And that was just consistent with our theory on plan design, which is we need to influence decision making by both the participants and also influencing the decision making of the behavior of the service providers. So we used plan design to influence these behaviors in the form of reducing office visit co-payments. When we did that, in 6 months, we got a 40% increase utilization to the medical group that we were wanting everybody to go to from a quality and a cost standpoint. Lowering the coinsurance, paying full cost so the participants don't pay anything, that gets their attention. Reimbursing deductibles, being very clear in your plan with regard to possibly limiting certain procedures or the conditions under which they can be provided, strictly enforcing coordination of benefits provisions. The idea is to bend the cost curve, shepherd the participants to the providers you believe to provide the higher quality of care. And that's where Global One got my attention, as well as bundling all of those components so the participant doesn't have to worry about, is everybody in their network? It's all being done for them. And as Michael said, we too used a bonus incentive to reward the participant for making the effort to do that. The other thing that I liked about the bundled approach through Global One is on the larger cases, they also provide stop-loss insurance so that the plan sponsor can be more comforted that there may not be a runaway problem here. So that was just an extra layer of protection for the plan, which we found to be very beneficial.
Great, thanks, Ken. So Scott, to you, Global One spent, certainly a lot of time developing the patient experience side of it, when the plan member does come to Global One. Can you talk about that, please?
Yes. So earlier I talked about the network, which is, quite a bit of work to put the network together, the provider network. But the thing that is probably most rewarding and very fun to see is the patient engagement side. So our call center, when a patient is scheduled for surgery, our call center will then call the patient, go through everything about the surgery from a financial standpoint, full transparency. It's one bill, one out of pocket. For a lot of these plans, like Ken Michael are talking about, they don't have any out of pocket. So we'll go into full explanation and talk about the savings bonus that's been implemented by the various plans, and make sure they're fully aware of their financial responsibility on the front end and any potential savings bonus that they will get as a result of using the program. We also start during that call a collection of patient-reported outcomes. And so we start that, and then we follow up post-surgery. So it's an independent polling of patient-reported outcome data that we use in our quality ranking that I'll talk about a little bit later. The other piece that Ken and Mike talked about particularly was the, educating the success in Monterey that we learned, just kind of boots on the ground, was educating the providers. So we have a provider advocate team, and their sole responsibility is to stay in touch with the providers, talk about, any new programs in their areas or a new program rolling out in their area, so that they're aware of the programs, and they can, as these members come into their offices, that they can start the discussion with them at that point. As we all know, there's no better way to start a discussion around member benefits than from the provider themselves. So having the providers' offices starting to talk about that's been actually something that has been extremely useful and productive.
Scott, yeah, you opened the door to quality, and clearly in a lot of programs, while it's talked about, we all know it's kind of a missing ingredient, especially in terms of some hard data in terms of provider performance. So maybe talk about what Global One's doing in that respect.
Yeah, so there's basically three components to it. It's something we put a lot of time into, and we feel it's quite unique. So we have the first thing we do is we're getting external quality data. Basically, it's payment data from two different sources. One which is primarily focused on commercial payment data, and the other is on Medicare data. So we're getting two data feeds that are basically showing basically complications and infections and any post-surgery complications that we can pull a look at from the surgeon. As ASC operators in that experience, we are also collecting and requiring the collection of the ASC data that's standard in the industry from the ASCs, and then the patient-reported outcome piece, which is the patient perspective. So we have the surgeon perspective, looking at that quality piece, the ASC quality data, and the patient data, and then we're rolling that into a composite score, which is, I think, on the next slide. And so we basically put it into it's a 0 to 18-point scale. Reds we stay away from, reds and yellows, and then the gray even is kind of a transition point, but we try to focus on steering patients to the green providers in the higher quality rankings. And we use that data when we're working with plans with MCSIG and with Ken's group.
So I'm really interested in Mike and Ken, your thoughts on this notion of rating doctors and scoring doctors, and more importantly, not your notion, but also how your plan members might think about it. Mike, why don't you start?
Well, thanks. For us, quality is really important, and we want our members to get good outcomes. And when we first started doing this back in 2015, we actually looked at 20 cases that were ortho cases, could have gone through the program, didn't, and 8 of those cases had complications. We paid out about $640,000 to $650,000 in extra fees because of lack of quality. So, and these are pretty good facilities around here. They rarely do make mistakes. They're super expensive, but they typically have pretty good quality. But, that year, the bundles, we had 75 and 0 complications, right? And so that was really important for us. It continues to be important. I think as you look at quality for doctors, you also have to consider, locally, there's a lot of cardio surgeons that will take really easy cases, and they have really great quality ratings, and they do well with members. And then you look at some of them up at Stanford, and they get slammed because they're operating on 2-pound, 3-pound children doing open heart surgery. And so I think you have to consider a couple different sources. So I like the approach that Global One's taking, where you're looking at several different things. And because there are some really high quality providers out there that, because they take the tougher cases, they may not rank quite as high. But for us, it's really important. The green and dark green areas are where we've tried to engage our members, and they've loved the quality. I mean, for years and years and years, we've had just phenomenal results. And that speaks well, because then they'll tell their friends and family about it too. And you get a lot of people coming back for a second surgery because it went so smoothly. I mean, surgery's never fun, but if you can eliminate a lot of the challenges and problems with it, people will have a much better experience, and it's better for the plan sponsor as well, because you save money on the backside.
Ken, rating doctors, what do you think?
Yeah, it is real important. As much information to be provided to your participants when they're in the decision-making process is very helpful. And it's a team approach. It's not just the doctors, it's the quality of the facility and the anesthesiologist. And I think, Mike touched on it really well, but what we want is we want to shepherd them and do the heavy lifting for them. So by being real comfortable with Global One's approach to combining quality physicians with facilities, it's a win-win situation, and it just makes it a lot easier in a difficult situation when anybody's facing surgery. So having this information as a plan sponsor and being confident in it is very, very significant.
Mike, you've tracked performance data under your program very closely, and I know you've got some to share with us, which we think is interesting. Please.
Yeah, so we've been working on this for the past 9 or 10 years now, and but for the last 6.5, we've done really, really well. So, we've got just over 6,000 covered lives. I talked a little bit earlier about the 75 bundles in 2015. It went flawlessly, but we ended up saving on average just over $14,000 per case. Our ortho cases are usually between 20 and 40,000 in savings, and then you get a lot of littler stuff. ENT stuff usually is a little smaller. But 2016 through 18, we saved about $1.5 million a year. Last year was a banner year for us. It was phenomenal. We had $3.6 million in savings. We turned around and paid about $400,000 of that as a secondary fee to somebody else involved. And then we shared about $200,000 of that with our members in shared savings rebates. So the actual plan savings to us was about $3 million after all was paid out. But amazing ROI, even with those payouts, you're still north of 1,000% ROI. So, for us, it's been a phenomenal savings and one of our best programs, and we've saved over $10.6 million to date. That's just the actual savings on the surgeries. That's not talking about the quality savings. Out of these, 1,000 surgeries we've done, there's been one complication in 1,000 surgeries. So, we had one person who lied to their doctor about pain management and was taking 3 or 4 things they didn't tell the doc about, that called 911 and got transferred out. But the surgery went well. There was no complications. They just weren't honest with their doc. The other one was just a moderate complication. So, for us, the last several years, they've been batting .999. I mean, that's amazing. I don't know of any baseball team that wouldn't pick up a player batting, .999. So for us, it's been phenomenal, and we're super excited. There's a couple more bundles we're wanting to work on. Our members, like they mentioned earlier, are interested in birthing bundles and some other fun things. So for us, it's been a great experience, and we've done really, really well because we've worked so closely with providers in Global One for the past several years.
Great. We've already had a couple questions come in on this now hospital pricing and hospital issues we'll return to in a second. First, though, Ken, maybe address, a lot of employers, plan sponsors hear from their claim administrators that, it's problematic or not even allowed for the company, the self-funded employer, to do direct contracting. Your thoughts on this?
Well, I would respectfully disagree with any health plan that said that. And I think administrators and plan sponsors need to be very proactive in controlling their own destiny. We made our health plan aware of what we were doing, but aside from contracting with programs like Global One and Teladoc and many others to just supplement what we're doing, and in return for building in incentives to get people to use them, I just think that the health plans really should not be interfering with what a plan sponsor really needs to do in the best interest of their participants. So I rarely had any issue at all. As long as we were making disclosure, everything was fine. But administrators and consultants or plan sponsors should be proactive and not take no for an answer.
Yeah, good point. Before we could jump into other questions, Scott, maybe just what's on the horizon for Global One in terms of the program?
Well, we talked about the various links of the bundle. What's included in the bundle is refining that. And there's a lot of talk about 90-day bundles, and a lot of the BPCI Medicare bundles are really focused on 90 days, mainly because there's so much spend after the initial surgery. Commercial plans don't see that kind of spend like we do in Medicare, so the 90 days is probably not as important as the risk guarantee. So as Ken mentioned earlier, we do have started providing that as requested, working with a third party to insure the bundles, so that any complications that might occur are fully insured with the bundle. So, and that's where the quality comes in, because ourselves and a third-party reinsurer are going to be a lot more confident. The pricing to reinsure is a lot better if you're reinsuring providers in that green category. And so that's where the quality ratings for us will be really important.
So again, as a reminder, participants, if you have a question, we've got a number. Just click that tab and type your question in. Question here, explain the difference between bundles and reference-based pricing. This is a good question. Ken, you want to take a swing at that?
Sure. So reference-based pricing, at least in my mind, is where you build into your plan a maximum allowable payment for a particular device or service. So we looked at our claims history, and in certain areas like routine colonoscopy, routine mammogram, breast pumps, knee and hip replacement, we specified the maximum benefit that we would pay for that good or service. And we set that at our 75th percentile of all claims. So we were not looking to cut out and make it difficult for people to get these procedures or devices. We just wanted to eliminate the Cadillac pricing that might otherwise have been allowed by our health plan as an allowable charge. And then on the bundled side, as we've gone through, by just packaging everything up right on the table, it's all there, the facility, a joint if it's involved, the anesthesiologist, the surgeon, there's no network problems. Everything is just wrapped real tight, and it's just a small fraction of what the overall cost would otherwise be.
Great. Scott, question came in for you. You share your physician and facility ratings with participating providers?
We have not yet. We will probably do that in the future, but we're still in the early stages of getting our head around the quality score, and but we will be providing that in the near future. And actually, it'll be more intended, just to further comment on that, it'll be more intended to help educate them around the quality score and how to improve it, and developing, if it's low, developing a performance plan to, if it's a ASC they're working at that has a low score, or the patient reported outcomes are coming in or off. So it's basically more of a educational process is the way we're going to look at it initially, to educate the providers.
Mike, a question for you. How would a plan sponsor start this kind of program in terms of first steps? If you've been through that process,
that's a great question. So as a self-funded plan, you want to engage with a company that's already doing this and has all the quality matrices, because if you just jump in and start contracting directly with providers, it's hard to know exactly what the quality is and how it's going to impact your members. So for us, it was really critical that we had all of that information in place because we wanted a quality product. You know, a global one, there's a few others out there that do similar kinds of things. I would recommend working with one of those type of organizations, and then work with your local providers. You know, we take around the quality matrices for our local hospitals to them and have conversations with the executives every couple of years and talk about what they're doing well, where they're struggling. And we've actually had a couple fix some of the problems that we see there. You know, there used to be a local hospital that did an inordinate amount of C-sections, like north of 70% C-sections, that now they're one of the most sparing hospitals in the area. So I think it's really important that you do communicate with your providers, work with them, make sure facilities know what they're doing. Our local ambulatory surgery centers have 96% less infections than the average hospital. So let me just repeat that. Our local surgery centers have 96% less infections than the average hospital. And if you know what's going on and you talk to people about it and work with it and you share that with members, that's really impactful for them. I mean, if you're going to go get a surgery and you can reduce your chance of infection by over 90%, that's huge. I mean, even aside from the money and other things you're going to get, it has a really big impact.
Thanks, Mike. Scott, question is, if you're using surgery centers for bundles, is there a way to steer appropriate hospital cases to surgery centers?
That's a great question. It actually is something that we worked with Mike on. So the actually bundling around surgery centers is really probably the best mechanism in our mind to steer patients from higher cost hospitals to an appropriate ASC setting. So one of the things that's come up are patients that are being referred to the hospital that maybe were better, could be, more appropriate for the surgery center. And so the way that we are handling this, and it's again by, each partner we're working with, is a pre-authorization process. So the pre-authorization piece is really key so that you're pre-authorizing to the surgery center and not to the hospital. And then if there's a question, then we refer it out to a third party for clinical review, and then so we're not involved in that process, and it's being handled by a third party clinical review or a second opinion as to whether it's appropriate to go to the surgery center, whether it should be in the hospital. That way we're removed from that process. But then you have a process by where the appropriate patients can be, the majority of them can be redirected to the surgery centers.
Thanks.
Chip, can I add one thing to what Scott just said? I think it's also important to know that just because a physician may appear to be aligned with a hospital, that it is possible that the surgery center, one of the Global One surgery centers, would entertain allowing them privilege to move the case there.
Good point.
Chip, I also have a comment. So we've used expert medical opinions for a long time, just like Scott was talking about, appropriateness of site. 90% of cases can go to a surgery center without any complications or problems. But it is important for the doctor to feel comfortable doing that. And if they're comfortable taking it to a surgery center, that's really important to do. We engaged Best Doctors several years ago on spine and cardio and cancer cases because we were seeing a lot of medical harm at some of the hospitals and wanted to make sure people knew what their best options were before they went under the knife. And so we have about 89% of those that are either re-diagnosed with a different diagnosis or the appropriate care is changed for those three types of care. So if you can get your members better information and more information in advance of a surgery, it can really help them get the best care they can get. So I additionally encourage people to make sure people know what the best thing is for those people beyond just a second opinion. If you can get an expert medical opinion, makes a huge difference.
Great point. Ken, back on hospitals, one of the participants is asking, it seems like hospitals have been slow to accept bundles. Is there a reason for that from your perspective?
I think they'd be happier submitting their $100,000 bills and seeing what the insurance plans will allow. So, yeah, we've had a lot of pushback from the hospitals and the larger medical groups, which is why we just took it upon ourselves to just go our own way and establish a path for our participants to get higher or high quality, maybe even higher quality service through the Global One or through the bundled program. So the hospitals and the large health systems, they don't want to give anything up, and they make it very difficult to gain concessions from them. Although I will say in your local areas, by approaching the health systems that your greater utilization is through, you may find them willing to talk to you about making certain concessions in return for using your plan design to steer more participants to go to them. But that's a good question, though.
Yeah, good answer.
I have an additional question related to that, to Ken and Mike. Yesterday, the executive order was upheld for hospitals to provide pricing transparency. That's a huge step forward in what we're doing. So do you think that might change a little bit for hospitals now being more willing to look at bundles and to go down that road now that they're kind of their hand is being forced?
Mike, you want to take that one first?
Sure. I love the article. We read about that, and it's really important. I mean, transparency is critical for people to understand. When you go into a car dealership, you don't buy a steering wheel and wheels and an engine and a fuselage for your car, right? You buy a car. And so that's what's really challenging for our members to understand is, what am I going to pay if I go get this surgery? And it's been, bundles really help you understand what the price is. There's not, 20 parts, it's the price. And I know our local surgery centers have been extremely transparent for years. They have all the pricing on the website. You can go in and look at it. And there have been a couple hospitals locally that have done a pretty good job with that. We just for transparency, I was a CFO for a healthcare system, and a knee here in Monterey County, if it goes through Medicare, they're going to pay $30,000 to that provider. On a blue basis, through one of the blues, we would pay $89,000 at the two major hospital systems for the same knee. And if there's moderate complications, we'll pay $100,000 to $130,000 for that same knee. And if there's extensive complications, we can pay north of $200,000. That same knee replacement surgery I can get at the local ambulatory surgery center for $23,000, below the hospital Medicare rates. And with higher quality, less infection, I mean, it makes so much sense to use bundles in the best setting for your members. And as more people are aware of what this really price differences are, I think you'll see more come to play. We actually did have, I almost fell out of my chair a couple of years ago because one of the two most expensive in the state actually is now doing some bundles because they lost so much business, I think. So, you can move the needle, but transparency is critical to be able to do that. Ken?
Yeah, thanks. And, let's be realistic. The thing with hospital charges, which represent about 60% of a plan's average annual claim payments, is it's good if we can get that information out, and I think it's helpful and it's a step in the right direction. I don't know if I would use the word transparency, simply because hospitals can get away with charging most whatever they want. They just change their charge master and their charge codes annually. So as an example, we had an instance with one hospital marked up a charge for chemotherapy by 1,900% from year one to the next year. So that passes through as that now becomes their allowable charge. So that's where plan sponsors have to be really diligent. And fortunately, we paid our own claims. So we were kicking the tires, and we saw what was being done. So it's good to have the information. Getting people even to go research it is another topic for another day. But relying upon quality, I look at true value as the combination of an optimal medical outcome at a most reasonable price. That's the win-win proposition. And that's what, Mike, on behalf of his group and my group and other plan administrators strive for. So getting as much information as we can, but when you can roll out a program and know that the providers, top to bottom, are all high quality, low complication expectations, the price is all there, you don't have to worry about fighting over what's allowable, what's payable. It just makes it so easy. And at the end of the day, it's the outcomes and the overall wellness of the participants that is first and foremost in our minds.
Thanks, Ken. Scott, question for you back on quality. Do you have minimum quality requirements for a provider to be allowed in your network? And obviously thinking here both the physician side as well as, I guess, the surgery center side.
Yeah, that's a great question. Actually, because of the way we have grown up in the business, we first was focused on the network and putting the network together and pricing and contracts and stuff like that. We didn't use quality to admit members into the network. Now that we are having access to quality data, we are starting to look at the red and yellow would not be allowed in, and again, that's where the performance improvement program comes, is to go through that process with existing providers. So the answer is we did not do it initially. We're starting to try to use that now as we're looking at new providers to checking that box on the front end now that we have access to data. And I should, now we know there's so much data available. The difference between now and even 5 years ago is just a huge difference in access to payment data and looking at, actual complications by provider. There's one of the groups both the groups that we pull data from, they do risk adjust. And so we get some really, good data to look at. So we just didn't have access to that initially, and that'll get better and better as time goes on. But we will be using that more as we're continuing to expand into other states.
Okay, thanks. I'll throw this one out to anybody who wants to take it, or maybe I'll talk about it. What's preventing the wider adoption of bundles? Anybody want to take that one?
Yeah, I think there's a reluctance on the part of plan sponsors to go down certain avenues for fear of problems arising. I also think that most of our plans are so geared towards promoting staying in your network that a lot of participants will actually, at least in our group, because we were focusing on one large medical group, their thinking was if you go in the right door, they're going to keep you within the network and you're not going to have any problems. But I just find even within our organization, talking to other plan sponsors, there's just a lack of proactive thinking on their part. The consultants aren't bringing these type of programs to the attention of the plan sponsors so they know what's out there. And it's a shame that it's that way, but that's where Scott has been real good. He reached out and educated me on what they had, and in 5 minutes, I knew that I wanted to bring it to my board's attention.
I think another big challenge people face is a lot of the carriers, because they don't embrace bundles, they really struggle. And Ken talked about this earlier. You've got to really push for your membership to get what they need. There's a lot of carriers that don't want this carve out in place. Some carriers will actually help you do it in network. Like we're working with Blue Shield right now, and they love bundles. So, that's awesome. And that really can help you. I know, just like with carving out for surgery services, you can carve out a lot of things. If you can figure out how to make it work within your network, it can function even better. But some carriers are going to fight you a little bit, but stand up and do what's right for your membership, like Ken was saying earlier. I think that's a big challenge. I think as transparency comes out and you see more and more of that, you'll be able to get bundles into carriers easier. I think a lot of them are kind of on the fence right now. Should we do this or not? And as I think we get the next couple of years down the road, I suspect that several of these carriers will engage bundles, just like Blue Shield has.
Go ahead.
Scott?
Go ahead, Scott.
I was just going to add that, so the Blue Shield, obviously, we've grown up in the business for Blue Shield, so they obviously are big fans of bundles, but it really depends on who the third-party administrator is. If it's an independent third-party administrator, they're going to be easier to adapt to the bundles because they can, the payment mechanisms are going to be easier. What we've seen, because we've talked to pretty much all the major payers, is their systems don't really absorb the bundle methodology very well. So I think over time, as the systems become more sophisticated and able to pay prospective bundles, we'll see a better adoption. And we're seeing that now. We're definitely seeing some of that movement that since we've been doing this for a number of years now and have data to support it. It's just going to take some time for the, I wouldn't call them archaic systems, but the insurance systems really are working off old legacy systems. And as they're updating, and they can integrate with systems like our proprietary system at Global One, which manages the full bundle payment, and those become more interactive, then we'll see more of adoption. Or you pay in direct. I mean, Ken is probably the easiest one to work with because Ken pays his bills direct, and so he has full control over that. So it's probably the easiest group for us to interact with when you're actually paying your own bills.
And that's what I was going to add is if you are self-administered, you don't have to worry about going back through the health plan's payment system.
Well, panel, thank you. We allocated 45 minutes and we're over that time limit. I want to thank the panel for the great input we had today and information. Participants, thank you for taking your time. The bottom of this slide is my email address. If there are any questions or you'd like additional information, please drop me an email. We'll be happy to address that. Also, we're likely going to plan other webinars like this to provide maybe more details down the road. So watch your emails for that announcement. So everyone, thank you very much for your attention today. Have a great day.
Thank you.
Thanks, everyone.
Good luck, everyone.